Did you know postpartum hemorrhage is one of the leading cause of maternal death worldwide, especially in the developing countries like India? In today's video, I'm going to discuss in a very simple and clear way about the PPH, its causes, risk factors, symptoms, preventions, emergency management, and most importantly, that is nursing responsibility. Approximately 500,000 of women are died throughout the year due to this postpartum hemorrhage. So today's video is very important for nursing students, medical students, and obviously all the healthcare providers who are working with the maternal and child health. Hi everyone, I'm Ankita Sen. Welcome to my channel Nursing Sensation. I make generally educational videos for nursing students, medical students, and also make videos on women's health. If you were preparing for any exam or working in labor room or postnatal ward and understanding that PPH is crucial, this video is really going to be helpful for you. Let's dive in. So, first I will discuss about definition of PPH. So, what do you mean by PPH? When there is excessive bleeding after the baby born and the mother is hemodynamically getting unstable, that is known as a postpartum hemorrhage. There is excessive bleeding after the baby born. So what do you mean by excessive bleeding? How you can understand that? If it is a vaginal birth, so the bleeding, if it is more than 500 ml, so it's diagnosed as a PPH. If the woman undergoes cesarean section for the baby born, then if it is the bleeding is more than 1 liter or 1000 ml, so it's diagnosed as postpartum hemorrhage. Now, come to the types of postpartum hemorrhage. Generally, there are two types of postpartum hemorrhage: primary postpartum hemorrhage and secondary postpartum hemorrhage. When the bleeding is occur within the 24 hours after the baby born, this is known as primary postpartum hemorrhage. And when the bleeding is occur after the baby born and beyond 24 hours and up to 6 weeks of puerperium or the postnatal period, it's known as a secondary PPH. So there is two types: primary PPH and secondary PPH. So here is the MCQ tips for your exam. Most PPH cases are primary and these are more dangerous than the secondary PPH. So this is the MCQ tips for you. Now drives into the causes of PPH. Generally, we remember the causes of PPH by 4 T's. So first T is stand for tone. The uterine tonicity. When the uterus is not getting its tonicity and becoming atonic by its nature, that's known as a atonic uterus, which is a primarily and most common cause of postpartum hemorrhage. Next T is trauma. Any trauma or injury or tear into the uterus or in the cervix or in the vagina, and that cause the bleeding, is known as postpartum hemorrhage if the bleeding amount is more than 500 ml in a vaginal birth and in case of 1000 ml in case of cesarean section. Generally in cesarean section, the trauma is mainly occurring in the uterus. Tissue, that is retained placenta or the membranes inside. So when there is a retained placenta inside, so uterus is getting contracted and contracted, no time to get squeeze and relax, only the uterus is getting squeeze and squeeze due to there's a retained placenta or the cotyledons or the membrane side. So this is the tissue which is leading cause of postpartum hemorrhage. Then come to the thrombin. If there is a coagulation factor that affects that coagulation disorder, that affects the clotting factor in the woman's body, and then can cause excessive huge bleeding, uncontrolled bleeding, that is a cause of postpartum hemorrhage. So 4 T's are tone, trauma, tissue, and thrombin. I will explain this later way in a detail. So here is also a clinical tip for you. When the baby is born and you are assessing the woman's uterus, if the uterus is boggy, that's alarming for PPH. That's knocking for PPH. Now come to the risk factors. So generally the risk factors are divided into many segments. Like first is the maternal factors. What are the maternal factors? As advanced maternal age. If the maternal age is more than 35 years, that can cause the PPH. I mean, this is the risk factors. Then high parity. If the woman is having a multiple pregnancy previously and she is a multiparous woman this time, grand multiparity, this is a risk factors. Then anemia. Pre-existing anemia can lead to PPH. These are most common risk factors in our scenario. Okay. Then obesity. If the BMI is more, it's a higher risk of PPH. Then hypertensive disorder. If there is a disorder like preeclampsia or the health syndrome, that can lead to PPH. Previous PPH, the woman is having the history of postpartum hemorrhage or the PPH in a previous consecutive birth. So these women are more prone to have chance of getting PPH in this time when the baby is getting born. So these are the maternal factor. Now come to the factor which are leading or risk factor during the labor and the baby born. Like cesarean section is one of the risk factor. When the baby is born by the C-section, there may be a high chance of having PPH. Instrumental birth. When we are taking the assistance by the applying the forceps or the vacuum during the vaginal assisted birth, that may cause the excessive bleeding and leads to PPH. Prolonged labor is one of the most important risk factors for postpartum hemorrhage. Uterine atonicity. I have already explained about the tonicity. When the uterus does not contracted properly after the birth, so uterus is not getting its tonicity. It's known as the uterus atonicity. So this is also a risk factor during the labor and mainly after the baby born. Okay, then placental issues. Placental issues like placenta previa, abruptio placentae, or the retained placenta also, or the bits of the placenta, membranes of the placenta can lead to PPH. Now come to the fetal and the uterine factor. In case of fetal factor, you can say that multiple gestation, like if the woman is carrying twin pregnancy or a multiples pregnancy, that's an increased risk of PPH. Macrosomic baby, when the baby is healthier, bigger, okay, than rather than other babies normal weight, okay, so this is a healthier baby, big baby. So in that time, what is happening, the uterus is distended more rather than a normal distended uterus during the pregnancy. So what is happening when the uterus is more distended, so it's taking more time to squeeze and contract it and getting the living ligature. Living ligature is one of the natural ligature by which the bleeding is getting stopped and PPH not occur. But when the abdomen is distended, so it takes time and it needs more contractions to be contracted, and it's not able to do the living ligature, and the uterus also not able to maintain the tonicity. So this all leads to the PPH, increase of macrosomia, the over distended uterus. So then polyhydramnios, the cause are same. Amniotic fluid is excess, over distended uterus leads to PPH. Now uterine fibroid. In case of that also, if there is a fibroid, so this is a foreign body for the body of our body, and that wants to expel the body wants to expel the fibroid, and also this fibroid is taking some space in the uterus, so uterus is not able to contract properly and then leads to PPH. Okay, and other cause may be the like full bladder. Generally, when the bladder is full, we are not emptying, or we have forget to emptying, the woman is not able to void sometimes. So this bladder also sometimes giving the barrier to contract the uterus and maintain its tonicity. So these are the risk factors generally which leads to postpartum hemorrhage. Here there is a trick so that you can easily remember the risk factors of postpartum hemorrhage. So what I have said right now, postpartum, right? So partum is the hidden tricks. How? P is stand for prolonged labor. A is start for antepartum hemorrhage, either this may be placenta previa or abruptio placentae. R is the recent history of bleeding or a previous history of bleeding. Okay. T for twins or the multiples. Okay, I mean multiple pregnancies. Then U for uterine fibroid, and M for multiparity or the grand multiparity. So this is the full form of partum, which comes under the postpartum hemorrhage. You can easily understand or remember the risk factors by this partum. Now come to the sign and symptoms of PPH. So now up to this, what I have discussed, maybe you are able to tell me the sign and symptoms by your own, because all the pathophysiology in a little bit I have already explained. So in a sign and symptoms, what you can see first, as because the postpartum hemorrhage, what you can see? You are very right. We can see heavy vaginal bleeding or the excessive vaginal bleeding which is not controlled, and the women are hemodynamically getting unstable. What do you mean by hemodynamically unstable? When the blood pressure is getting low, the heart rate is getting higher. I mean, there's a tachycardia. The woman having, the pale and the calm and the cold skin. The women's skins are getting cold, and the women may complain you lightheadedness, then dizziness, fatigue, okay, and the woman can't talk with you properly that time. So these are maybe the signs and symptoms. And what you can assess, the uterus is a boggy in nature. It's not getting contracted. It's not hard like a ball. So it's boggy. Okay. So this is soft. This is the signs and symptoms of PPH. Okay. So now come to the recommendations by the WHO for the prevention of PPH. So here I'm going to discuss about proper recommendations from WHO for the preventive measures. Okay, so first, what we are doing, we are using the uterotronics for the PPH preventions during the third stage of labor, which is highly recommended by the WHO. So what are the uterotronics we are generally using? So they are saying like oxytocin, general injection oxytocin, IV or IM, 10 international unit we are giving just after the baby born, within 1 minute after the baby born, as a preventive or the prophylaxis of PPH. So this is also included in the active management of third stage of labor for the prevention of PPH. Okay, in setting where the oxytocin is not available, what we can give? We can give argometrines, we can give methyl argometrines, we can give misoprostol 600 μg as a preventive or prophylaxis measures. Even we can give a combined fixed drug combination like oxytocin and argometrines also. So these also are strong recommended medications for the prevention of PPH where the oxytocin is not available. Now, to prevent the PPH, a skilled hand is very important, because to prevent the PPH, so you have to be very gentle during the baby born. You should not be in a hurry. So baby born, the birth of a baby is a natural process, a natural phenomenon. So baby will come by its own. So there is no need to give any fundal pressure, no need to just pull the baby's head. There is no hurry in that. So baby will achieve all the cardinal signs or the mechanism of labor, and the baby will come by its own nature. So you have to be very calm and gentle. So when you maintain all that and you know the physiology of the birth, so you are the skilled birth attendants, right? So when where the skilled birth attendants are not available, oxytocin also not available, what we can do there? We can give the misoprostol 600 μg per orally as a preventive measures of PPH, where there is a no skilled birth attendance, there is a no oxytocin supply or availability, so you can give that. Okay, but remember what I have said here, give per orally, because misoprostol giving per orally works within 8 to 11 minutes, whereas when you are giving the tablet misoprostol per rectally, it starts to work at 90 minutes. So you can easily understand by orally it can start work faster. So you can prevent the PPH, or you can manage the PPH if you give the tablet misoprostol per orally or sublingually. Okay. So this can given by the community health workers to prevent the PPH. This is also very highly recommended or strongly recommended. Now, in setting where the skilled birth attendants like you are present, so that time you can perform the control contractions in the vaginal birth. When you are doing the control contractions, there is also no hurry. You are waiting for the separation of the placenta, then descent of the placenta, and the expulsion of the placenta. So there is 3 stages of the placental delivery, right, or the birth. So you have to wait. That's because you are skilled birth attendant. So where you are present, that time you can perform the control contraction with the counter traction to the uterus, so that there is a uterus will not come out. Okay, so this is your skill to do that. Okay, in setting where the skilled birth attendants are unavailable, okay, CCT cannot be performed, because if the skilled birth attendance is not present, the person will not able to understand the importance of CCT, the importance of giving the counter traction to the uterus, and there will be total uterus may come out, or the chance of PPH is more higher, because the person, the unskilled person will not wait for the placenta separations or the expulsions or the descent, so the person will pull. And for this pulling, maybe there is some written placental cotyledons or the membrane, okay, or it can be tear and written placenta can happen. So these will all lead to the provocations of the PP. So where there is a no skill by attendance, there is a no CCT will perform. Okay, so these are the recommendations by the WHO for the preventions of PPH. Now, come to the uterine massage. The sustained uterine massage is not recommended by the WHO, where you have already given injection oxytocin to a woman, because you have already given some preventive prophylaxis to the woman, so there is no need to do a regular basis practice of uterine massage normally. Okay. Now, abdominal uterine tonicity assessment in a postnatal woman is very important to diagnose early signs and symptoms of postpartum hemorrhage, because if you feel the boggy uterus, it's alarming for you. The woman is going to be bleed excessively or badly, and that can lead to postpartum hemorrhage. Even this can be a fatal condition for the woman. Okay, so these are the recommendations by the WHO. What can be the others? Like in antenatal women, you can find out the anemia. Okay, as I have told you, the risk factors is anemia. So if you find out the woman is having anemia or the polyhydramnias, or the baby, if the woman is having twins or multiples, so what you can, or the she is a grand multiparity, so you have to be treat all anemia and all this, and whichever is not treatable, like twin pregnancy and multiples or polyhydramnias, what you can do, you can have preparation by your hand, like arrangement of the bloods, and you have to be ready with the PPH kit, management kit, okay, or the toolkit of the PPH. So this can be helpful during the baby born. Okay, identify the risk factors and counsel the family and the woman accordingly, so that they will be also get ready that this can happen. This can happen, cannot be happen. Okay, and skilled person should be there in the labor room or the midwifery late care unit when the baby is born and mother is giving bearing down efforts. Slow birth of baby, placenta, membrane and cord is very essential. Let them delivered by naturally and normally. There is no hurry on that. Okay, so these are the preventive measures for the postpartum hemorrhage. Now come to the management. So what is the initial steps of management? So first is, you can't, it's an emergency condition, right? So you can't alone maintain or do all the things whatever you want to do for the management of PPH, because she is hugely bleeding, so you can't manage by your own, so you need a team. So first, call for help. So call for help for it's a PPH and I need help, so you need help of a senior nurse or a senior midwife, obstetrician and anesthetist, because hysterectomy or the OT for the written placenta removal may need it. So you need a anesthetics, also a surgeon with you as a helper. So call for help first. Then give injection oxytocin. If you have given already 10 international unit after the baby born within 1 minute, you can again start either in an IV or you can give in an IM injection oxytocin. You can repeat as a prophylaxis. Okay, what else? You can give fundal massage. Okay, you can give the bimanual compression to compress for 5 minutes continuously. You can evacuate woman's bladder by catheterization. Okay, you can start IV fluid, you can give oxygen. Okay, because 6 to 8 liter oxygen the woman should be maintained. Okay, you have to check the temperature, pulse, respiration along with the SpO2, which is very essential this time. Okay, because she is hugely bleeding. Okay, you can administer other medications like misoprostol tablet, misoprostol preferably sublingual or per oral. If the woman is not conscious or semi-conscious, that time only you can give per rectal. Okay, but it will take time to start working. You can give injection tranexamic acid, you can give injection carboprost, you can give injection methargine also. So these all are the drugs which will help you to control the bleeding. Okay, now come to the surgical option. What you can do first, when you are doing the bimanual compression and when you are taking out of your hands, is still bleeding, you can insert a tamponade, okay, a uterine tamponade, which will do the same work like bimanual compressions. Okay, then what you can do, if it is a trauma, you can start suturing from the bleeding point as soon as possible. You can start suturing. Okay, and if there is a bleeding from uterine artery, you can do the ligation on the uterine artery. And the last and the rarest one is the hysterectomy. So for that reason, you have to when you are asking the call for help, you have to ask for the anesthetic surgeons and the ready to be keep in hand. The OT has to be keep in hand ready. Okay, now come to the most important thing for which you are waiting for a long, that is the role of a nurse or a role of a medical students or a role of a midwife. So what is your role? So first is calm down yourself, because this is an emergency situation. I know you have your adrenal rush inside, but you should not show in front of anyone that you are also very tense, because you are the leader who is going to be, or you are the team member, one of the team member who are going to be manage this PPH and save the woman's life. Okay, so first calm down, call for help. Okay, and then plan what you want to do. First check the time when it's happened and what's happened, what are the sign and symptom you have see, what was the bleeding time, what is the conditions of the uterus. So all this assessment you have to keep in mind first. Then monitor the vital signs, because if she is bleeding, she is hemodynamically unstable. So monitor the vital signs and document. Ask someone to document. Okay, so keep someone ready for only for the documentation. Okay, then assess the bleeding and the uterine tone, what I have told you. Then administer the IV fluid. So here you have to make 2 large hole cannula. Okay, in one normal saline or the crystalloids will go, and in another 20 international unit oxytocin in 500 ml of crystalloid will run to control the PPH. So you have to do that first. And when you are doing the IV cannulations, that time you have to draw blood sample for the grouping, cross-matching CVC and the clotting profile. Okay, that you have to send in urgent requisitions, an urgent form to the lab, and get ready with the blood and the other reports in hand as fast as you can. Okay, so send someone to do that. Then prepare for everything which is going step by step, and ask the team member to close the loop if she has or he has did the job what you have instructed to do. Now come to the woman and the family member who are there in that positions. They are the people who are in a stress because they can't understand what is happening. Suddenly the baby born, everything was fine, what happened suddenly. So the emotional support to the family and the woman is very important. Explain them what is exactly happened and what we are doing to manage the situation, so that they will calm down themselves and they will cooperate with you. Okay, and then come to prepare the emergency interventions. I mean, what are the management I have told you before, so do that accordingly, and then document properly with the time and of the full signature and with your designation, so that anyone if asked who was there that time, who has documented. So these are the legal issues, you should be very clear on that. Okay, so these are the things you have to do as a nursing students or a medical students or a midwifery students. Okay, so this is all about the postpartum hemorrhage. Remember, this is a very crucial conditions, clinical conditions in labor room or in midwifery late care unit or in a OT where the cesarean section was going on. And this can happen suddenly without sometimes no alarming sign and symptoms. Okay, so you have to have your good clinical eye to judge or to understand the risk factors and refer or manage accordingly and timely, so that you can save the woman's life. And if you save the woman's life, you can save the baby also, as the mother is getting saved, and you can help the family also, because the woman and baby leads to the family. Okay, so hopefully this video is helpful for you. for your nursing education, for your clinical practice, for your labor room experience, for your exam too. If you find this video was helpful, please give a thumbs up. Subscribe my channel and press the bell icon so that you will not miss any videos in future. Till then, stay with us. Thanks for watching.